And good morning, everyone. I am Dr. Ajinkya Nanavre from Emcure Pharmaceuticals. I welcome everyone to the no thrombosis workshop in acute ischemic stroke. In the previous workshops, we had very unique and interesting case discussions, and we are looking forward to have a fruitful discussions today as well. The objective of this workshop is to showcase unique cases in the management of acute ischemic stroke and to gain insights from the moderators and wisdom shared by our course director. And it is my honor to introduce our faculty for today. Let me share my screen. So I first welcome our course director for today, Dr. K. Asokan sir. Sir is chief neurologist and head of neurosciences at department at Sri Ramakrishna Hospital, Coimbatore. Sir is life member of Indian Academy of Neurology and Neurological Society of India. He is also active member of American Academy of Neurology, Movement Disorder Society of India. Sir has been a president at Coimbatore Neurological Society and at Tamil Nadu and Pondicherry Association of Neurologists. He has presented papers in many national and international conferences on stroke and epilepsy. Also conducted various international drug trial studies in his department. Sir has special interest in stroke therapy. Welcome, Dr. K. Asukan, sir. Then I welcome our first moderator for today, Dr. Jayanta Roy, sir. Sir is director at Stroke Program and senior consultant at Department of Neurology, Institute of Neurosciences, Kolkata. He is a certified neurosonologist accredited by American Society of Neuroimaging 2005. He is recipient of 2005 American Society of Neuroimaging William M. McKinney Award for the best manuscript based on the clinical research in neurosonology. Sir is an executive committee member of Society of Neurosonology, India, member of Educational Committee at Joint World Stroke Congress, Hyderabad. He has more than 36 publications in various reputed national and international journals. He is also editor of various neurology books and has been a guest faculty at many prestigious national and international neurological meetings and conferences. Welcome, sir, to the workshop.
Thank you.
Then I welcome our second moderator for today, Dr. Varun Kataria, sir. Sir is consultant neurologist at Medanta Hospital, Indore. He has more than 14 years of experience and a member of Indian Academy of Neurology and Neurological Society of India. His main areas of interest are acute stroke and its management, epilepsy and epilepsy surgery. He has been taking great initiatives for public awareness and education regarding stroke and epilepsy. Sir has also expertise in electromyography, headache management, neuromuscular disorders, spinal disorder, epilepsy treatment, and many more. Welcome, sir.
Thank you.
Then I welcome our first expert speaker for today, Dr. M. Abid sir. Sir is consultant neurologist at Sri Chandrasekhara Hospital, Hosur, Tamil Nadu. He has more than 7 years of experience post-DM and he has been a part of multiple studies. Sir has presented 6 papers at various national conferences like IonCon, ACCon and ECTRIM. Welcome, Dr. Abid sir. Yeah. Then I welcome our second speaker for today, Dr. Sanjay Kumar V. Kaminwat, sir. Sir is consultant interventional neurologist at Apollo Reach Hospital and Lotus Neuro Hospital, Karimnagar, Telangana. He has completed fellowship in stroke intervention at Tamil Nadu Government Multi Super Speciality Hospital, Chennai. He is presently working as associate professor and HOD at Department of Neurology, Chalmeda Anand Rao Institute of Medical Sciences, Karimnagar. Sir has thrombolized more than 150 patients till now. Welcome, Dr. Kaminwar, sir. Then I would like to hand over this session to our course director for today, Dr. K. Asukan, sir, for his opening comments and context setting. Sir, over to you.
Thank you, Dr. Ajinka, for your kind introduction. It's my pleasure to invite all of you for this workshop on no thrombosis. I thank Team Emcure for arranging this meet, and I thank every one of you for sparing time to attend this meet today. As I have told repeatedly in the previous meetings also, it is more than 2.5 years we are going on like this, monthly meet, and we have covered lots of interesting cases and difficult cases to deal with. And really, we had learned a lot from those complicated cases. That's rather from all the expertise across the world. Of course, we gain knowledge every time, and we are rather more into the subject each time. And today we have got two moderators, Professor Jayanta Roy and Dr. Varun Kataria, who are going to moderate the session. And we have two speakers with us, Dr. Abid and Sanjay Kumar, who are going to share their experience and discuss their cases. So without wasting time, I'll straight away call Dr. Abid to present his first case. Dr. Abid?
I'm sharing my screen content, sir. Are you able to see the screen?
No, not yet.
Now?
Yeah.
Yes, yes. It is not going to full screen, sir.
One second.
Yeah, it is visible like this.
Make it full screen.
Yeah, now?
Yeah,
yes,
fine.
Good morning to the respected members of this August Forum. Today I'm going to present two cases which I have seen in my recent last 3 months of my practice in Hosur. First, case one was an elderly male who was in his 70s, just presented 30 minutes from the onset of left upper limb and left lower limb weakness. He came to the hospital, and this was a new setup. Actually, there is no stroke thrombolysis going on in this part of the district in Tamil Nadu. So this was our first case we initiated in this district here. So everything was on from the scratch here. So most of these patients get referred to Bangalore for thrombolysis. So we have started this. This was the presentation of the patient. When he came, he had a gaze preference towards right, and they are not able to move his left upper limb and left lower limb with a NHS scoring of more than 12. And since he has presented very early into the illness, and within 30 minutes of presentation of this stroke, it was recognized by the ER people. And I was informed, and we came and we spoke to the attenders, and we decided we will go ahead with thrombolysis. We just invited this known stroke metrics, which we started in our casualty, to have this metrics for every case which is coming for stroke. First, we document the random blood sugar. As BP was 170/80, as GCS was normal. To the door, he came within 30 minutes, but for the CT protocol, it took about 25 minutes because it was a new center, and everybody has to get understood and acquainted with this stroke thrombolysis. So the CT protocol took about 25 minutes, and then we went ahead with the lysis of the patient with tenecteplase 0.20 mg per kg. We did not use 0.25, but we took 0.20 because patient did not know that he was found lying on the ground actually. So we took him, and this was the CT scan. This is a 16 slice CT scan. So we went ahead and did the CT for this patient. CT picked up it was normal, no hypodensities was seen, but 2 or 3 perforatous infarcts were seen in the left corona radiata, and but it was not correlating with our clinical presentation. So we went and thrombolized this patient after 25 minutes since the when he came inside the hospital. So CT is normal. So after thrombolysis, patient did was communicating, the gas deviation had settled, and he was discharged. He was able to walk and go back. The CT angio was also performed.
Okay.
And there was no large vessel occlusion. This CT angio, this machine is a 16 slice CT. Normally, we need a better CT scan to have a look at it. But here we have to go ahead and see whether there's a large vessel occlusion. And since he had a good improvement clinically and CT angio was also normal, the patient was discharged the day after, 2 days after the onset of stroke. So this was the first case. And shall I proceed with the second case, sir, or we will discuss?
Yes, yeah. Please go ahead with the second case.
Case 2 was a little bit more interesting actually. She's a 71-year-old female. She came to ER at 9 a.m. and with dysarthria, lasted for 2 minutes, found to have a BP of 190/100. Advice admission, patient denied, claiming that she was having dysarthria due to its identalous nature and fever she had 2 days before, and she denied admission, went home. She slept at home, got up at 5 p.m., found to have worsening of weakness, came to the hospital at 7 p.m. At that time, she had an NIHS of 4, and she was primarily a cardiac patient. She was on dual antiplatelet. Patient was waiting in the cardiac OPD to meet the cardiologist to show his complaints. But at the OPD, she deteriorated, and this NIHS was 15. Then the stroke code was activated at around 9 p.m. So she came at 7 p.m. and all the way in the cardiac OPD for 3 hours, and it was activated at 9 p.m. So from morning 9 a.m. to 9 p.m., that was a stuttering progression of the stroke. So, this was the patient at the time of seeing in the ER. She was conscious, responding. She was able to lift his hands. This was at 9 p.m. But she came walking actually to the hospital actually. And once the stroke code was initiated at 9 p.m., then we did not wait for further. We went ahead and did the. By the time the echo was ready, because the cardiologist was much bothered, he said it was a cardiac event. We did the echo. Echo was having dilated LA, LB, a kinetic anti-receptum, and no clots. So we went, since it was a late presentation out of the window period, since there was 2 deteriorations in the hospital itself. First at 4 to 9 p.m. she has deteriorated. So we went with the MRI protocol for this patient. MRI shows already diffusion restriction in the right MCA territory, but flare was beginning to show changes in the MCA territory. But perfusion scan of the same patient was having perfusion blood. Some perfusion tissues were there preserved in the right MCA on the cortical area. But that was an M1 occlusion. So we discussed with the attendants that the patient might not, may have a 50-50% chance in having a benefit in the neurological recovery. And because it was almost 9 a.m. and we are taking the patient at 9 p.m., more than 12 hours since the onset of stroke, we discussed with the pros and cons, but the attendants were willing to go ahead with this thrombectomy. So with a 50% caution, we have taken the patient for thrombectomy, and we started the groin puncture at 10:30, and we had a difficulty in this patient in terms of negotiating the catheter up. We used the two stent retrievers. We used the AS penumbra. When we initial plan was to aspirate the clot, but we found that one of the catheter was not negotiating the ophthalmic segment, and it got stuck there, and we had a difficult times in negotiating the catheter via the ophthalmic segment. But later on, we were able to send the 3 max, and the port was engaged, but it was not able to suck the port. So we decided to use the stent retriever at that point of time. First, we decided to, as it was like the cost constraints, we decided to go with an Ox solitaire to do a stent retriever. But 2 attempts did not catch the plot. Then we thought there's no point. We then changed to a new stent retriever. New embotrap was opened, and 2 attempts were again done. And by second attempt, the plot was captured. And this was the picture at that time. This is the this was the picture of after the stent retriever was used. But you can still see some of the clot is still resisting in the distal M1. So we decided and wait for 5 minutes again. It was showing signs of decreased flow. So we decided to give an intra-arterial connective place of about 4 mg for this patient, and subsequently this was the second attempt we did try to remove the clot. And we are able to remove it, and the clot came at 2 p.m. and 10:30 is 9 hours since the onset of stroke. And we gave after this to intra-arterial connective place also, and after which we had a good TK3 flow of time for this patient. And TCD on day 1 and day 2 were showing good flow in the MCA territory. And subsequently, the patient improved, and we discharged the patient on day 8 with good rehab. So even though it was a stroke which was taken after almost 9 hours since the onset since morning, patient did good recovery in terms with rehab, and there was no loss of life. That patient did not undergo decompressive craniotomy. Otherwise, such patient would eventually go and develop decompression. So we were able to save the patient from decompression, and with good rehab, she improved. So these are the 2 patients which we did in the recent times. I present the first case for the new center where we started, and this is the second case, the third case from the center where we have to use intra-arterial connective place for maintaining the recanalization of the thrombus after it was aspirated. Thank you, sir.
Thank you, Dr. Abid. With the permission of the moderators, I'll start the discussion. I think you will take up with the second case first. Okay.
Yes, right. Yes.
So the second case, of course, what you have done is post-thrombectomy thrombolysis. And the post-thrombolysis.
No, sir. Yes, sir. Post-thrombectomy thrombolysis.
But what you call is thrombolysis before thrombectomy is bridging. Now there is a concept of thrombolysis after thrombectomy. This is called the post-thrombectomy thrombolysis.
Yes.
So we know, all of us, we know very well, there is 2 things, EDT and ENT. EDT means emboli occurring in the distal territory. ENT means emboli occurring in the newer territory following thrombectomy. Because the clot is crushed and the microemboli thrown, they go forward, and small clots, they may set in the microcirculation and cause microemboli. Or sometimes, in your case, it has occurred in the just distally, beyond M1, that is M2. Instead of going to the distal, smaller microcirculation, it has occurred in the just distal M1 itself, or M2. Yes. So that's called EDT, emboli occurring in the distal territory following thrombectomy. Of course, following thrombectomy, if your TIC is not 3, and if it is rather, your previous thing I saw, it was something like 2B or 2A. That is there is circulation occurring beyond occlusion, but only half, and the distal is not getting perfused. That's because of the emboli. And with the tenecteplase, now what you have shown last is TIC3, complete reperfusion. I think the patient gets good benefit. So that you have done a good job. And another thing, your MRI and other things show the core infarct is still small only. The only penumbra is large.
Yes, sir.
And the perfusion scan you had shown, where the penumbra is large, core is small. So such of these patients, definitely they do get better up to 24 hours. In your case, only 9 hours, 9 or 10 hours.
10 hours.
10 hours should not be a matter. Such of these cases, they benefit up to 24 hours. And another thing, this M1 tight occlusion. Did you have re-occlusion in the same area after thrombectomy?
Yes, sir. Sir, the two things happened actually. For the cost constraints, we first opened the oxygen retriever. It did not catch the clot actually. After the fourth attempt only, it catch the clot, but there was no re-occlusion, but the thrombus was persisting after the removal of the clot. So then we went and did the thrombolysis also after that.
Exactly, that's what I'm telling. See, first pass opening, clot is lysing and getting opened. It's a very good reperfusion. Second, maybe better. Third, or more than 3 passes, you do get chances of disintegration of the clot and going to the distal part and getting occluded. More number of passes, this disintegration and the smaller clots go to the distal area, get blocked. And where your, of course, tenecteplase post-thrombectomy thrombolysis does help. Maybe that's how it helped. Nice, good case. And your first case, of course, routine case, but only thing, since you had shown the gaze paresis, what I thought is large cortical infarct.
Okay.
Large cortical infarcts only they present with the gaze paresis. But
Okay.
you have shown in the CT angio also that was there was no large infarct and there was no large vessel occlusion. Improved
Yes.
well. Thank you.
Yes.
Thank you. Professor
Thank you.
Jayantara, please, your comments.
I agree with you, sir, regarding the discussion points you made in the disaster. And regarding this intra-arterial tenecteplase, I personally do not have any experience of using tenecteplase intra-arterially, but though in earlier days during the IMS trial days, we used to give alteplase intra-arterially during intra-arterial thrombolysis. And sometimes people gave GP2B3A also intra-arterially in case of reocclusions post intervention. But tenecteplase, I think this is a safe thrombolytic, so there is no harm in giving it off label. And this, the result also was good, thankfully, and we did not get much of reperfusion hemorrhage. So I think this is a very interesting case, late intervention based on tissue window. So well done. And again, in the first case, as Dr. Ashukan mentioned correctly, the gauge deviation, which is not seen in perforator stroke, that is usually a hemispheric stroke, and it was clearly visible in your video, in the picture. So I do not know, I mean, whether that has the plot has resolved spontaneously before you actually did the CT angio, and patient also got better after the thrombolysis.
Yes.
Yeah, this might be one question, but this is a very standard approach. But in a new setup, arranging everything with the door to needle time 25 minutes is hell of a job. So congratulations.
Okay. Thank you, sir.
Dr. Varun, your comments, please.
So very nice cases, Dr. Abid, and the same thoughts I also came across me also, that starting a thrombolysis in a new setup is very tough. And I can remember a few years back when I started it, it was very tough to educate our staff, to involve radiology, to involve ICU, to empty the CT room on time. And then that too, you could do the thrombolysis in very good DNT door to needle time. That's very good. In the second case, I had one comment. In such cases, when we already know that the patients are of have some cardiac problems. Do these cases require echo before thrombolysis? Because there is, like in this case also, the LA was dilated. Sometimes we have LV clot which can disseminate after thrombolysis. So do all such cases warrant echo before thrombolysis? That's a common question that comes across all of us.
Sir, can I answer this question?
Sorry, sir. This was actually, patient was in the cardiac OPD. So they did the echo and then they came down. So we were very confident in giving that. But your question is like, I also had that fear if the patient come and I would have given a clot busters, if everything would have lies, even more, it would have called for disaster. Right?
Yes. Well, I think that is not a mandatory before you decide to thrombolize a patient. The point is valid, but practically it's not feasible in most of the cases unless you have a very smart ER physician who's conversant with an echo and who can put the probe for a 10-second look at the LV or LA and find out a clot without wasting much time and in delaying your door to needle time. But since he went for mechanical, so I'm really not really worried about what is there in LA or LV at that point of time. Well, after that, definitely we have a look at it. And it could be in all probability, this is a cardioembolic stroke, M1 occlusions. So that's it.
Yes.
Yes, sir. I totally agree with you. No, because we don't waste time evaluating further, including cardiac evaluation. At the most, what we do is ECG, one blood sugar, one BP. That's it. Most of the time we need, and of course, good CT or if possible, MR, diffusion weighted, or stroke, including MRA, and rule out large vessel occlusion, also the same stroke.
Absolutely.
And of course, you go ahead and the stroke mechanism or stroke causes, you start evaluating later. Yeah, that's it, sir.
Absolutely.
Thank you. So that is very good, very nice. And we will go on to the next case, Dr. Sanjay Kumar. I invite Dr. Sanjay Kumar to present his next case.
Good morning to all. I'm audible?
Yes, very much.
Good morning, sir. Good morning to all. Actually, before starting this case, I just want to comment on the previous second case, actually. As they have done, tried to aspirate the clot for 2 to 3 times, it was not possible. But there was some flow after that second or third attempt he was stealing. But it would have been a disaster because they have given 4 milligrams of tenectase, which is a very high dose, I guess. There may be chances of hemorrhagic transformation if you are giving locally 4 milligrams of tenectase, if such a large infarct size is there. But they are very lucky that it has not got into hemorrhagic transformation. Because recently we tried to extract a basilar artery thrombus and we are not able to extract that thrombus with 2 attempts of aspiration only. We have not used solitaire or embotrap that time. And we have given only 1 milligram of tenectase locally. And after 10 minutes, we have taken another shoot in which basilar artery was completely open and bilateral PCA were feeling very good. TK3 flow we achieved only with 1 milligram of tenectase locally, because as basilar thrombus will be of large size, long segment, but in this it was like only M1 occlusion, and they have already tried for 2 to 3 times with solitaire and embotrap. So I think that 4 milligram of giving tenectase locally was very bold step, but still they were very successful, and there was no, most important is there was no hemorrhagic transformation, and the already patient was on dual antiplatelets. So chances of hemorrhagic transformation would have been more, but they are very lucky to save the patient without any complications. So I congratulate Dr. Abid. And as he was telling that they have started IV thrombolysis only 3 months back, and in 3 months of time started doing the patients directly into the neurointervention. So it's a very fast journey, what I think. So congratulations, Dr. Abid, first.
Then, coming to the point of intraarterial dose of 4 mg, sir, this is a protocol which we follow with our SNF Academy with Dr. Shakir Hussain. We are doing a trial right now in EMS Hospital, Perindalmanna. where we have assigned 2 mg, 3 mg, and 4 mg, and even 1 mg. But the trial results will be back, maybe out by maybe next year. So what they have done for this plot, what we have found with those set of patients, the 1 and 2 never worked actually. So what was working was then 3 and 4. Maybe depends upon the heterogeneity of the plot what we are seeing. And what we saw was most of these red clots, they respond to this intra-arterial tenecteplase. White ones, they don't respond. They just stay there only. That there is no point in dealing with the white ones. The red ones do respond, but since it is a 9-hour stroke and it is already we are at the brink of the time.
9 hours is very well into the window period, I guess.
Yeah, no, but like this with all this morbidities, news center. So I was also literally trembling only. So first, to be frank, the first dose was 1 mg only, and it did not open.
It did not open. Oh, okay. So after first 1 mg you are given. So after that, so the third attempt of Embo trap, what was the flow? It was TK2 or something?
TK2 only. And so we then we decided to give another 3 mg at a full shot. So totally 4 mg. So like that only that 4 mg was achieved. First 1 mg was given. It was not opening. So remaining 3 mg we just used and with open. So probably the red clot nature would have been more in that patient. So it was like desperate attempts to save the brain, and since once we go inside, we at least start working from the spinal level. Your brain gets stuck somewhere. So that's what happened. That's what.
Very good. Congratulations, doctor.
Very good. Again, my small comment. Thing is, you are lucky. You didn't have reperfusion injury because
that's what. Yes.
Your core. In fact, was smaller in size. Only mostly penumbra. What you had shown in the perfusion imaging, core in fact was less. So that's why probably escaped. There was no perfusion injury. If the large core, in fact, you would have ended up with hemorrhage with this dose of tenecteplase. Yeah. Thank you, sir.
Thank you, sir.
Sir, with your permission, I will start my presentation, sir.
Yeah, please go ahead.
Slides, please.
Okay, I will share my screen. Is it visible?
Yes.
Yes. Sir, please let me know when to move to next slide. Hello. Sir, you are on mute, I guess.
Yeah. I'm Dr. Sanjay Kaminwar. We have recently started our stroke program in Apollo Rich Hospital. Initially, we used to do only IV thrombolysis since last 5 to 7 years. Now we have gone into neurointervention. I did fellowship in Tamil Nadu Government Super Specialty Hospital in Chennai under Dr. Periya Karappan sir for 6 months. So now we have started DSS and mechanical thrombectomy in Karimnagar for the first time. So I will share this case. Actually, very simple case for you all, but just my experience of this initial experience of the case. So this was a 35-year-old male patient who presented to a ER almost 60 kilometers from Karimnagar, and the physician there called me regarding this patient. And on his history, there were no risk factors, as he is very young, 35-year-old, presented with weakness of right upper limb and lower limb. And he was inability to speak. So it may be left MCA infarct with right dense hemiplegia and aphasia. And when the patient reached there at their hospital, it was only of 2 hours duration. Next slide, Ajinkya. So there I asked him about the vitals and all, and I guided him how to do NIH score and all those things. So he told me that blood pressure was 150 by 90 mm of Hg. And according to his history and examination part, he had aphasia, facial weakness, left complete hemiplegia. So we calculated that NIH score was 14 and power in left upper limb, lower limb, according to him, was 0 by 5. Next slide. So I asked him, the MRI brain was available in that center where he was working. I asked him to straight away to get MRI brain with angiogram. It was only of 2 hours duration. Meanwhile, I asked him to send the blood investigations which were required. So next slide. So this is the MRI which he got and forwarded me. It was a complete left MCA occlusion looking like, because entire left MCA is gone subcortical as well as cortical involvement is there. There is a clear-cut diffusion restriction in left MCA territory, along with there is ADC suppression. Next slide. As we see that there are no changes on the flare, so there is definitely diffusion flare mismatch is there. They don't have perfusion study, and we don't want to waste the time in that, because we got clearly diffusion flare mismatch of 2 hours duration, and the angiogram showed. Next slide. So we can see and expect that there was a large vessel occlusion of left M1 segment, complete occlusion. There are no collaterals also seen. And he had left clear cut, left M1 occlusion, left MCA infarct, right hemiparesis, aphasia, young patient without any vascular risk factors of 2 hours duration presentation. And this investigation and all took almost 1 hour there. So it was completely 3 hours. Next slide. So MR angio was showing left M1 occlusion. Treatment options were discussed with the relatives. I asked him that what we can do is we can do IV thrombolysis there, and you can shift the patient for mechanical thrombectomy, SOS. So I asked him like the drip and ship things. So he should counsel the patient that they are going to do IV thrombolysis, because he is eligible candidate initially, because 3 hours duration only. And if it is not getting lysed with this injection, we can plan for mechanical thrombectomy. During that time, you can shift the patient to our center. Next slide. So meanwhile, these blood investigations came and all were almost within normal limits. So he was eligible for IV thrombolysis as the M1 occlusion was there. Next slide. We thought of giving Tenictase. I told him that patient weight was 60 kg. I asked him to give 15 milligram injection bolus with 0.25 milligram per kg body weight dosage. He has given that over 1 minute, and immediately the patient was shifted to our hospital and counseling the patient that we want to do mechanical thrombectomy. But there was one twist in this. Next slide. On arrival at our hospital, time duration, it took almost 2 hours after that IV thrombolysis. So the duration total was 5 to 6 post-stroke. He was clearly eligible for mechanical thrombectomy. But when he arrived at our hospital, his NIHS score dropped to 4 from 14. Only there was subtle facial palsy, little aphasia, and there was a drift, only drift in upper limb and left lower limb, right upper limb and right lower limb. So NIHS was only 4. So there was dramatic recovery from 14 to 4. Meanwhile, next slide. Option of mechanical thrombectomy, still we were discussing with the relatives, because we don't know patient has improved, but still there will be M1 thrombus. What we can do is we can just do DSA and document that we have done successful IV thrombolysis. M1 vessel has opened. If it is a partially open, we can give intraarterial, or we can suck the thrombus again or aspirate the thrombus. Meanwhile, the cath lab was busy. We were very this thing that time. Primary, they have taken one case for primary angioplasty, anterior wall MI with cardiogenic shock patient was there, and some complication happened, and the patient was stuck in the cath lab. So our cath lab was busy. So what I thought, I have given them an option that as patients clinical recovery was there, we don't know about the vascular territory, because there was M1 documented occlusion. So we don't know whether post thrombolysis it has opened or not. What we can do is, before doing a DSA, which is invasive, we can do repeat MR angio and see if it has not opened. Again, we can plan, because it was only 6 hours duration. Another 1 hour we can stretch to wait that cath lab will be this thing available for us. So meanwhile, we did a repeat MRI. Next slide. So obviously, as clinical recovery was there was clear opening of whatever that occlusion was there, it was resolved. And there was almost complete flow, complete recanalization of left M1 we got. Next slide. The infarct size was also slightly reduced, as the picture or quality is not good, but the size was a little decreased. But what we want was clinical recovery. Over a period of 8 to 12 hours, his aphasia completely improved. Next 24 hours, patient started walking without support. So this was the patient where we were planning for mechanical thrombectomy, but we would have done DSA if our cath lab was available for us that time, and we could have documented that TK3 flow with only IV thrombolysis. But with some issue, technical problem, we did again repeat MRI brain and angiogram to show that there was a complete recanalization with 0.25 milligram of per kg body weight of penictase. A young patient, and we saved with only IV thrombolysis, and there was no need of going for mechanical thrombectomy. So, any comments?
Yeah, Dr. Sanjay is a really very interesting case. Thing is, that's what so we all go through. First is M1 occlusion or IC occlusion, the large vessel occlusion, not basilar occlusion. It's a large vessel occlusion. Naturally, we prefer mechanical thrombectomy because clot load is heavy. Normally, that doesn't get laced with the IV thrombolysis, what you give. So, but some cases, it is not the rule for all the 100 cases.
Yes.
But some cases, they do get laced and open up nicely. You get IC3 as you had demonstrated. But what anyone or I would have done in this patient, of course, if cath lab was free, soon after receiving the patient, he is improving, no doubt. Since it was the largest occlusion, would have gone for DSA. Probably would have seen the DSA, the complete opening of the vessel. So we stopped with that. Any remaining this thing, clots or whatever it may be, would have proceeded further. But as you said very correctly, clinical improvement is more important at any given time. Clinical from 14, am I correct? From 14 to 4.
Yes, 14 to 4.
Significant improvement. So in this case, if at all DSA would have done just to confirm that the vessel has opened up, and to stop with that. Otherwise, I think what you have done is a very correct thing. Probably the patient is lucky the cath lab was busy. Otherwise, should have taken it and would have costed more. Yeah.
More, sir. Yeah.
But this is what normally we do. Large vessel occlusion, of course, within the window period, thrombolyze and take him up for DSA. If it is everything clear, to stop with that. Anything remaining, of course.
We can do. Yes, sir.
Yeah. Meanwhile, if clinically the patient is improving, I feel in some of the cases still we can wait. If the patient is improving really well. Thank you. Professor Jayanta Roy.
Yeah, thank you, sir. I think, Sanjay, your case is very interesting, but for any neurologist or stroke specialist, we love this kind of patients coming to you within 2 hours, giving you enough time to react and deliver the right therapy. Just 2 comments. One is usually at 2 hours time, we don't need to look at the mismatch. We don't need to. Mismatch we see in case of
up to 4.5 hours.
So, I mean, for me, one DWI restriction just to confirm stroke or a low ADC, and that is enough. And yeah.
But in our scenario, the patient's history, sometimes they will not be knowing the exact time. Just they will tell blindly that it is a 2 hours duration.
Now,
so sometimes
I agree with you fully.
It may be 6 hours duration, but there will not be attendant, and they may say that it is just 2 hours duration.
Absolutely. Absolutely. I agree with you. And if your MR protocol for acute stroke is set up like that, usually if we combine DWI ADC and one flare and one maybe TOF for your vessel,
yes, sir.
The TOF takes, I think, around 3-4 minutes to get a good quality picture, and flare another 2 minutes.
Yes, sir.
DWI is 30 seconds.
30 seconds.
Also the
ADC 30 more seconds.
It should not be more than 6 to 8 minutes.
Yes,
so
sir.
If the protocol is set like this, I don't mind having 4 sequences available with you, which you have done rightly. And second is, this is exactly what happened in Extend IA-TNK trial.
Yes, sir.
They gave tenecteplase and they found higher recanalization rate before you actually did thrombectomy. So you were lucky, patient was lucky, it worked very well, and you got a fantastic outcome. So I think that is the crux of the thing is, this is why people are still not jumping onto direct MT. People still believe that give IV and take the patient to MT rather than direct MT.
Yes,
so we have a number of RCTs now looking at the equal efficacy of direct MT compared to bridge. But I think in our setup, I still believe that bridge should be done.
Yes, sir.
And because there are a lot of advantages, except only those centers where everything is available at 30-minute warning, lab, your interventionist, everything. So, which is probably not the case in our country in most of the centers. So,
Exactly.
it should be the way to go.
Exactly. I think that's the very valid point, because a lot of times the cath labs are busy with cardiologists, and we many times have to wait, and we have to, literally fight with cardiologists to get the lab. So I think the major point here is that the 2 hours, the time duration that you got when the patient was shifting here. So you got the time. Usually we don't get the time. We usually just inject and we shift him to the cath lab when in our centers. But in your center, the patient was traveling. So you got the time when he actually improved. You could see the clinical recovery. So that's a very good point. Secondly, I think you did the flare. That's a good point, because it was more than 1/3 territory was involved in diffusion weighted images.
Yes,
so
yes.
I think that's a important point, that traditional contraindications for thrombolysis that we used to read has to be now reinforced to all the people, that you have to look at the tissue and save the tissue. Thirdly, my point is a lot of centers are now shifting to CT based thrombolysis. So your personal this thing of choosing MR based, is there any personal this thing, or a lot of centers are doing just CT angio and then going ahead with thrombolysis? Any particular choice for choosing MRI based thrombolysis protocol?
Sanjay, are you asking Sanjay?
Yeah. Actually, what I do is this thing, as in our center in Apollo Hospital, we have both MRI as well as a CT. But the time takes for MRI and a CT, it doesn't make maybe 2 or 3 minutes difference. As sir was telling that MR angio will take TOF 3 minutes, or diffusion weighted imaging 30 seconds, another 30 seconds for ADC, 2 minutes for flare. So the shifting time and all will be the same, maybe 3 to 5 minutes. But what I feel is the picture, what we get on diffusion and flare mismatch, because always we don't know the exact time, because patient may have a 5 hours duration stroke, or maybe 6 hours duration, but they have not seen the patient. Just they are telling that it's a 2 hours duration. We don't know. But we will be more confident of doing thrombolysis on the basis of MRI if it is available. If not, just do CT, rule out hemorrhage, do CT angio if it is a large vessel occlusion, do thrombolysis and shift the patient for DSA. That's what I do.
Yes, Dr. Sanjay. Dr. Varun, I'll add on one thing. See, as far as stroke management is concerned, definitely MRI stroke protocol is far ahead. And the question is availability and time. This is what we repeatedly talk about, availability of MRI and time taken for MRI. If you talk about the time, as many of us, we feel 8 to 10 minutes. It's not a big time. Okay, if you go for CT angio, same time is going to happen. So time is not a problem. And availability, suppose if there is a machine within the campus next door, go for MRI. Only thing, there should not be any contraindication for MRI. Like the pacemaker, even the recent generation pacemakers, they don't say it's not a contraindication. Or other the patient is very restless, where you cannot restrain, things like that. Otherwise, depends upon the availability and time. If it is available and you can get it done, better, and you can go by rather than plain CT.
Right.
Yeah.
Sir, can I comment on this?
Yeah, this thing.
Sir, can I comment on this?
Yeah, please.
Yeah, I think there are points in favor and against of both. The best thing is which one you practice in your center, which one your system is more geared up with. That is the most important thing. I mean, many centers do CT-based thrombolysis in the world, and many centers do MR-based, and they both show good results and good reproducibility. So I think it is interchangeable. Any center can choose MR in certain situations, or the vice versa. In my center, in my experience, I do more CT-CTA than MR. There are distinct advantages, like movement in the MR gantry is a problem. CT movement thing is relatively manageable. CT angio gives you a better resolution because it's a contrast based angio sequence rather than a TOF, because a little bit of movement cannot give you a good quality TOF image. So these are the challenges. But having said that, it all depends on where you practice, what your system is tuned with, and whatever gives you the best possible assessment in the shortest possible time, go for it.
Yeah, agree.
Agree.
So,
one more thing, sir.
People like us, we are more tuned to stroke protocol, MR stroke protocol.
MR stroke protocol. Just one thing, sir. Actually, the thing is, when we are doing CT brain, and if it is a normal, and if we do at the same time in another patient MRI brain, and there is a diffusion restriction, ADC suppressed, and some normal flare, it's very this thing feasible and will be very easy to convince the patient, because CT is normal, still patient is having hemiparesis. Patient attendants will ask while counseling, sir, CT is normal, what we are going to do? What happens if we discuss complications and all those things? They will always tell, sir, CT is normal, why we are doing this thing? But if we do MRI and if we show the patient attendants that there is a diffusion restriction is there, these changes are there, this can be reversed. If we tell them, then patient acceptability and counseling will be more easy. That's what I feel, and this thing in clinical practice, what we see.
Well, Sanjay, let me answer this question. Sir, can I go ahead?
Please go ahead.
So you probably need some gray hair to answer this question, because I have been thrombolizing for more than 20 years. So, and in our days, we started with CT-based thrombolysis.
Yes, sir.
So I think the approach was pretty much straightforward. You do a CT and you know there is a stroke. So you tell them there is no bleed. And at the same time, the stroke is there, but there is no big damage yet. So this is the time to act. Don't waste time.
Exactly.
Tell me yes, and we go ahead. So they buy it. So it all depends on the way you put it. So I think the most important parameter of getting a confidence and informed consent from the patient relative is your attitude in the ER room, your activism, your approach, and your sense of urgency is enough to convince them that you are a good meaning guy. You are trying to salvage this patient. And in 99.9% cases, I tell you, they buy it.
Yes, because stroke is ultimately
from my gray hairs. I think Ashokan sir will agree with me, right, sir?
I agree with you. Last meeting also same question raised by someone, I forget the name. He was also telling the same thing. See, if you take the plain CT and show the patient CT is normal, still you have to thrombolize with 40,000 rupees of injection. Then they might ask, why to spend 40,000 on a patient where it is negative? Normal, rather negative or normal. So such as, but you told us very correctly, gray hair. Probably you have to get gray hair and start convincing. But what Sanjay says, taking such a difficulty and convince the patient, more than that, it's easy. It's available with me. The stroke protocol available easily with me. I can get it done. I can make it positive or negative, and I make out the large vessel occlusion also, if any, at the same stroke. Why can't I do that? But still the answer is, if that is available, it's very much in time, you can definitely go with the stroke protocol. That's the answer. And we don't say, don't go for CT plain. This is what practiced worldwide. Everywhere, people are doing this only. But if it is available easily, yes, MRI stroke protocol is good, no doubt. That's what we feel, sir. Absolutely. So, as you said, whatever is available, with whatever you are comfortable, you can get it done. Yes.
That's right.
Yes, sir.
So is there any question waiting for us from the audience or anywhere?
No, sir.
Huh? No.
Nothing.
Okay.
Nothing means, I think it's time for closing.
Right, sir.
Any other comments from any of you, sirs?
No, I think we had a very good discussions, very practical discussion. And both the cases are very good. And every case has some learning point, though they are standard acute stroke cases, but we learn from the different minor points also. So it was a good discussion overall. Thank you.
Yeah.
Thank you to the presenters.
Yeah, Dr. Varun, any comments?
Yes, sir, I concur. We can conclude.
Okay. Right. Abid, okay? Shall we go ahead?
Good.
Right.
Thank
Okay. Sanjay?
Yes, sir.
So I thank every one of you for your fantastic participation. I thank all four of you, both the moderators, both the speakers. We did a wonderful job. And we had, of course, every time we are learning, this time also we learned new points. And I'm thankful to all of you. Thank you. Thank you once again.
Thank you, sir. Thank you all. Have a nice Sunday.
Yeah.
Nice.
Over to
workshop as always. And I am sure our audience must have learned so many new things today. Around 100 people have joined today for this workshop. And thank you so much for joining even on the Sunday morning. And I would like to thank Dr. M. Abid sir, Dr. Kaminwar sir for presenting those interesting cases. And thank you, Dr. Jayanta Roy sir, Dr. Varun sir, Dr. K. Sukan sir for your expert comments and your great practical insights. So we would like to under your guidance for many such future programs, sir. So with this note, we will close this session. Thank you everyone again. Bye. Have a great weekend.
Yeah, bye-bye. Thank you.
Bye,
Bye,
sir.
sir.
Bye-bye.